Can we start the recording? Good afternoon, everyone. iTech India welcomes all the participants for today's special NDLS session. Today's topic is mental health issues among PLHIV, and the speaker is Dr. Maithili Umate. Dr. Maithili Umate ma'am is currently working as an associate professor with the Department of Psychiatry at GGMC and JJ Group of Hospitals, Mumbai. She has extensive experience of working with PLHIV with psychiatric and psychological issues. She has published many papers in international and national journals. Participants to please note that all the questions will be taken up at the end of the session. You can either post your question in the chat box or we'll give mic access at the end of the session. We welcome you, ma'am, for today's session and request you to start the session.
Thank you for the warm introduction. Yes, so we'll start today's topic, that is mental health issues amongst persons living with HIV. So what is the objective of today's talk? First, we'll be covering what is the burden of mental health disorder, both global as well as national. Then we'll look at the associated disorders. Mainly, we'll be looking at the more common ones, that is anxiety disorders, mood disorders, psychotic disorders, hand and substance use disorder. Then we'll be looking at one important assessment tool called as the PHQ-9, and we'll be discussing the mental health programs, both the NMHP and the DMHP. And last but not the least, we'll be looking at the role of the ART Center in mental health issues. So first and foremost, let us start with what is health. So health, as you all know, is a state of complete physical, mental, and social well-being, and it's not merely the absence of disease or infirmity. So what is mental health? It goes on similar lines. That is a state of mental well-being that enables people to cope with stresses of life, realize their abilities, learn well, work well, and contribute to the community. Whereas when we look at someone having a mental health issue, we are talking about a clinically significant disturbance in an individual's cognition, emotional regulation, or of behavior. So what is the global burden of mental disorders? In 2019, it was seen that one in every 8 people, or that is 970 million people were living with some sort of a mental disorder. Most common, anxiety and depressive disorder, as you can see, at 301 and 280 million respectively, which also affects children and adolescents. The next common ones are the other affective disorder, that is bipolar mood disorder, then is schizophrenia, eating disorders, and disruptive disorders. So what is the burden when we look at in India? So in India, what we have seen is that mental health condition in children and adolescents are seen to between 6 to 12%. A recent NMHS survey found a prevalence of 7.3% in children and adolescents. And overall, 8 to 13% of children are estimated to need mental health services. So what are persons living with HIV prone to? As you all must be commonly seeing even in your setups, that they are quite prone to psychological ailments, per se due to HIV itself, or also due to opinions and experiences regarding HIV in their surroundings. They may face multiple types of psychological issues like depression and anxiety, which I told is pretty common. Along with that, we also see a lot of internalized stigma. If we look at children and adolescents, again, that we are discussing about them, what we see is that mental health issues are more common as compared to the general population. Even you look at the other vulnerable group, that is women, again, in that mental health conditions are more prevalent than those without having HIV. So again, if we look at these associated disorders, as we said, the commonest one was depression. Anxiety disorders. Depression is seen to be 2 times more than that in the general population in age-matched people. Other mood disorders also, like say bipolar mood disorder, there is a 10 times higher risk. Even in case of psychotic disorders, the risk is even 2 to 10 times higher Then hand, which is that HIV-associated neurocognitive disorders, they are also commonly seen. Substance use disorders, that is use of, say, tobacco, alcohol, or even other drugs like, say, cannabis, opioids, are also seen in quite a few people. Sleep disorders are seen in 10 to 50%. Post-traumatic stress disorders also seen. Severe mental illnesses are seen in less than 15%. So we go to one of the common types, that is anxiety disorder. So what is anxiety? I mean, anxiety is a word all of us use in our general discussions. Like we say, I felt so anxious when someone said something. So what do we mean by anxiety really? So anxiety is the emotional response of an excessive fear to a situation. It could be real, imagined, or perceived. So say if somebody is anticipating an event, so it could be a perceived threat, or it could be a real threat, or sometimes could be even an anticipation of a threat. Now, what are the common anxiety disorders seen? Those are generalized anxiety disorder, panic disorder, social anxiety disorder, agoraphobia, and specific phobias. So, what are the symptoms we see amongst these? In terms of generalized anxiety disorder, what we are seeing is a lot of people report an excessive worry about a number of events. So, you realize the anxiety is generalized. It is not related to only one specific stressor that the person is facing, but it could be even about trivial issues like day-to-day activities, like tomorrow kaam pe jana hai. So they'll be worrying that tomorrow what will I do? How will I get ready? So it could be worry about trivial things. And the person will report that they find it very difficult to control this worry. They themselves realize the worry is too much and out of control, but can't stop it. Then is the second is panic disorder. As the word suggests, panic. Panic, when we mean it's not just general anxiety, we are talking about a very severe form of anxiety. So what happens in that these episodes are rarely a single episode of panic. Very often people get recurrent panics, and sometimes many a times they are unexpected, what we call as out of blue. Like suddenly they say that without anything, out of the blue, I started feeling very anxious. So the person could have anxiety, palpitations, dryness of mouth, tremulousness. That time could have a choking sensation or difficulty in breathing. Could feel that things are going out of control. They may even feel that fearful that something will happen, I may die, a feeling of an impending doom, that something is really going to go wrong or I'm going to go crazy. So, and these episodes very often are repetitive, and a lot of behavior at times is focused on trying to avoid such attacks. So say a person who's got a panic attack, say in a crowded place, next time would feel more worried to go in a crowded place, would try to avoid such a situation. There are people who will report a lot of time that if the situation is going to be crowded, they avoid it. So if there is a fair, or there is there's going to be a lot of crowd in the train, so they avoid all such situations or prefer to take somebody along with them to look after in case something goes wrong. So panic disorder is very often associated with the second last, if you see, is agoraphobia, where the person feels a marked fear about any situation where they feel they may have a panic attack. So it could be anywhere, like an open crowd, or say when they are alone. Very common, a lot of people say that this happens when they're in a very enclosed space, say in lifts. Uh, so invariably they keep avoiding such situation or try to escape. Then the other common anxiety disorders we see is social anxiety disorder, where a person has marked fear of specifically of social situations. So they are afraid of situations when a lot of people may be looking at them or may judge them or may scrutinize them, and they feel anxious that how am I looking? How will they look after? Evaluate me? Will they look at me in a negative manner that there's something wrong with me? So this is typically what you see in social anxiety disorder. Then there is something called a specific phobia, which is also common. That is, there is a fear or anxiety about a specific thing. So this is something actually, if you see, very common in practice. Like you'll see a lot of people who are afraid about a specific thing. Some people could be afraid of snakes. Some people could be afraid of birds. So the fear is irrational and excessive. So now let's look at one more disorder in similar spectrum, that is adjustment disorder. Now, adjustment disorder is something that you all could be seeing. Very often it comes related to a specific stressor. Like say it very often we get this diagnosis when they are just diagnosed with the status of HIV. Or if there is a sudden situation, like they have lost the job or they have lost a loved one or they lost the support of near and dear people. That's when we very often see adjustment disorder in the course of this illness. Often what we see is with depressed mood that a person has difficulty in adjusting the situation and along with that feels sad, doesn't get proper sleep, or has often crying spells, doesn't feel hopeful about others, sometimes may even feel that life is not worth living. Other symptoms that can be seen with anxiety are nervousness, panic, or feeling very anxious or jittery. Other could be a common picture, that is, a person could feel both the sadness, the depressive symptoms, as well as the anxiety symptoms, what we call as with anxiety and depressed mood. Sometimes we also get with disturbances in behavior, like very often, sometimes instead of the classical symptoms like just sadness, tearfulness, you could get irritability, aggression. They may get suddenly very reckless, may suddenly indulge in more unprotected sexual acts, or could indulge more in drugs use, alcohol, or other any kind of antisocial behavior. This also can happen in the course of adjustment disorder. And then others are with the mixed symptoms of all these or an unspecified symptoms. So how do you manage anxiety disorders? So the first line of treatment for anxiety disorders would be psychotherapy. That is counseling sessions where you have more of a supportive counseling sessions and some behavioral activations. Then long-term psychotherapy, often useful in these are say interpersonal therapy, interpersonal group therapy, or cognitive behavior therapy or group support psychotherapy. We can also give short-acting benzodiazepines, mainly lorazepam, alprazolam, or a longer-acting ones like clonazepam. As psychiatrists, we more often use clonazepam as compared to the shorter-acting ones. Now, the golden rule is that you should use this briefly only, as far as possible within the first 2 to 3 weeks only to avoid dependence, because that is the biggest risk. Apart from this basket of benzodiazepines, which we give for acute treatment, what otherwise can also be given and which can help more in long term is antidepressants like mainly tricyclics or SSRIs, which are very useful in treatment of anxiety disorders. So let's come to now mood disorders, which is one of the most common illnesses that you will see. Now, these are two types, depression, which we call also as unipolar depression, and bipolar affective. So the difference mainly being in bipolar, there are two poles. So apart from depression, there is also a manic or a hypomanic spectrum, which is seen. So in these now, it is very commonly seen that anxiety is comorbid in as much as in 9 out of 10 cases will also have a comorbid anxiety. Sometimes you'll also see that it's not the patients who complain, but it's family members who will say that they feel that their family member is having some issue. So very often you will see somebody with speaking lesser than usual, or someone having melancholic features. That is, the ones who will say that I just don't feel any emotions, or I just don't enjoy things like before. I just don't feel pleasure. Classically, what they will have is an early morning awakening, getting up in the morning, very early, like 4 o'clock, 5 o'clock. And classically, there is also a diurnal variation of mood, which means the mood is worse or feeling low is worse in the mornings, and it gets slightly better as the day progresses. Also, along with it, what you will see is guilt or weight loss. Other features that are often seen as catatonic features, that the person becomes very withdrawn, uh, the movements become very slow, or could be having some psychotic features like, hearing voices, hallucinations, feeling that others are making fun of them. So now if you see in depression, there are two classes of symptoms primarily. One is the mood symptoms, we call as the affective symptoms, and the other is the physical symptoms or the somatic symptoms. Now, these are very important to distinguish. Why? Because the somatic symptoms, if you see, are very common in the illness itself. in HIV itself or the comorbid illnesses due to HIV. So say something like losing appetite, or weight loss, or having disturbances in sleep, or having slowness, or having fatigue, or having poor concentration. These are all physical symptoms. These commonly overlap with other issues. So when we are suspecting depression, you should look for the affective or the mood symptoms, that is feeling low, or classically they will say, I don't enjoy things whichever I liked before. Or they may say, I feel very guilty about, they feel that something is wrong with them and they are at fault and others are in problem because of them. Or they could also feel hopeless. Now, see, hopelessness is a very core symptom that you should elicit, because hopelessness, like feeling that, isse kuch nahi ho sakta, things can't get better, and there is no way out of whatever I am in. Now, this is often a precursor to developing suicidal thoughts. Now, if we look at it, depression itself can be a risk factor for HIV. So, how? See, a person who is depressed, okay, could have a poor adherence to ART and could have poor HIV treatment outcomes. It may impact their behavior, so they make wrong choices. They may increase their drug use, or they may start taking more alcohol, or they may have poor choices in partners. And in general, they could have more self-destructive behaviors. On the other way, you can also see that people with HIV also develop depression. How? One of the hypotheses is depression itself causes injury to the subcortical areas in brain. Then the discovery of illness itself could be something which can push a person into depression. Other biological factors are like neurotropin itself produces changes in deep gray structures. Then, as the illness itself worsens, and there are exacerbations of the illness and further complications, depression can set in. Then the social isolation, chronic stress, demoralization, loss of support, stigma, secrecy, lack of confidence, which all come as a psychosocial aspect of HIV. These all again alienate a person and can lead to depression. Last but not the least, you should remember there are certain medication, that is ART itself, which can lead to depression. So why is it important? Why are we talking about this topic today? Why is it important to identify and treat depression? Mainly because depression itself is also a chronic illnesses with multiple relapses. It has a long course. It is itself one of a very top three disabling illnesses, leading to poor quality of life. Now, depression itself, as I was explaining before, when a person starts feeling demotivated, starts feeling hopeless, and feel that there is no use, it is quite likely that they will not be adherent to ART itself and can indulge in high risk behaviors, and there is a definite risk of suicide. So, when do we call it as depression? See, now, depressive symptoms are much more common that we know. Like, if there is some problem, it's very often that, when something goes wrong, then that day we feel very sad, we feel very upset. And we say that, Arey, mujhe bahut depressed laga. But that is not depression. So, what do we mean by depression? For depression, it's more of a pervasive pattern. Pervasive in the sense a person is feeling depressed most of the time, at least for 2 weeks. And this leads to changes in the way they behave or the way they interact. So we call it as change in functioning. And either of these two symptoms should be present. Either the person is having a pervasive means most of the time is feeling sad, low, or has decreased interest or does not feel pleasure in most of the activities and most of the time. So apart from this, the other symptoms are weight loss. Sometimes paradoxically, we also get weight gain, or insomnia, or paradoxically hyposomnia, psychomotor retardations, that is slowness. Then there could be loss of energy, feeling worthless or guilt, decreased concentration, recurrent thoughts of death, and poor self-esteem. Now, any of these above 5 symptoms are required for the diagnosis, apart from one of the two which I mentioned before, that is low mood or decreased interest. So let's now look at one case study to understand this better. So there is this individual, a 56-year-old man, PLHIV, who has been on treatment TLD since 3 years. His CD4 count has been 750. Now the stressor which has happened is his mother's death, which happened 3 months ago. Now he's feeling low mood, he's feeling irritable, There is early morning awakening. Now there is passive death wish also. So think over it. How can you manage this case? Would you all like to go over this? So what can we do? One is we should assess for his risk for suicide. See, any person who's feeling depressed, very often we feel that, we feel awkward to ask because we feel that we are giving them ideas. No, it's not so. A person having any suicidal thoughts very often may not disclose. It's we who have to ask them. Anyone who feels low, we should always by default ask if there are thoughts about attempting or wanting to commit suicide. So one thing that you do in this case is assess for suicidal risk. You take a detailed history and you work upon this. Then what can be advised is counseling for him. And in this case, a psychiatrist referral can be made because there is already a passive death wish. If there is a suicidal risk, then definitely it has to be done. So how do we manage? First, we look at for suicide risk assessment, as I was talking, what does it include? First, one important marker for suicidal risk assessment is past suicidal history. Currently, right now, how much do they intend to harm themselves and how much the person is feeling anxious or the person is feeling hopeless. So these are important points to ask. Then see if depression is there. In this case, what we saw, bereavement is a possibility. Counseling should be done, and especially for ART adherence, because if the person is feeling hopeless, it's quite likely that he is not going to be adherent to ART. In this case, yes, antidepressant medication should be given. If it is given, it should be given for at least 6 to 9 months. Then you should be referred for psychiatrist. Now let's look at the vulnerable groups. In children, very often we will not have the usual presentation of depression. Rather, what a child may do is that there will be a refusal to go to school, or the child will become very clingy, and typically they will cling to their parents or the caregiver. Their academics will worsen. They will not be able to concentrate in studies, or they might become very irritable, or not interact with others like before, will not play with friends like before. So, depression in children will be very different than as compared to adults. Then, if you look at adolescents again, there will be a lot of acting out behaviors. So, apart from similarly having problems in academics and poor concentration, they would have more of indulging in drug use. They will start smoking or using alcohol or other drugs, or start in more antisocial behaviors, start taking risk, or we also indulge more in sexual acts with others, often which will be unprotected. Whereas now, if we look at old age, in old age, it's much more common that the depression will be underdiagnosed or undertreated. They'll be very less likely to seek help. And you should not forget that ageism. What do we mean by ageism? That, with older age, the symptoms that are seen in depression can often be dismissed as a part of aging. So that is something you should never miss. But why? Because it's much more likely that older age people who are depressed, they are more likely to commit, that the suicide can be successful. Adolescents also attempt a lot of suicides, but it's much more likely that old age, that is geriatric population, often have a higher rates of completed suicide. Now we look at the other disorders, that is bipolar affective disorder. Again, the risk is 10 times higher. So what do we see mainly in this second pole of mood disorders? That is, they would rather have an inflated self-esteem, or they would feel grandiose. They would not feel the need for sleep. They say that bina soye bhi humko fresh lag raha hai. So there could be a decreased need for sleep. They could be more talkative than before. They could be having racing thoughts, or again, similar to unipolar depression, they may not be able to concentrate, but in this case, they are much more likely to be distractible. And they could then indulge more in risky behaviors, like, spending more money, or having a higher libido, so more sexual indiscretions, or could start trying some unrealistic business deals, or might become very irritable and aggressive and could even turn violent. So why these need to be managed? Because the behavioral problems can very often get out of control. So what we need in this case is more of apart from medications, we need injectables, that is quick acting parenteral antipsychotics. Often we give benzodiazepines like antipsychotics, haloperidol, olanzapine. These are more commonly used. Benzodiazepine against diazepam, lorazepam are commonly used. Apart from haloperidol, we also give zuclopentixol along with promethazine. Uh, Now, the SOS injectable is often followed by 8 or 12 hourly oral doses of, then you give typical or atypical antipsychotics. More commonly in PLHIVs, we prefer atypicals as compared to typicals. So, what is atypical antipsychotics? These are olanzapine, quetiapine, ziprasidone, or risperidone. Amongst benzodiazepines, in oral medication, what is preferred to give a longer acting molecule like, say, clonazepam, which is given. Or now, a person with mania is quite likely to respond quicker to the treatment than, say, a person with depression. But you should remember that they often require maintenance treatment to prevent further relapses. Last but not the least, psychotherapy is extremely important, and in this, we should include the family members as well. Now, let's go to the next disorder, that is psychotic disorders. The prevalence is noted to be 5 to 15%. The mechanism of causation is complex. So sometimes it can be caused by the illness itself. Sometimes the medications can also induce a psychotic episode. Or sometimes the infections which are comorbid with the illness can also precipitate psychosis. And what are the clinical symptoms that we see? Most common, yes, all of you all know, it's hallucination. Amongst hallucination, auditory, visual, and tactile are much more common. So hearing voices, seeing images, illusions, or tactile feelings, these are more important. Delusions will be irrational beliefs which are held very strongly despite any evidence. They are very often paranoid, like they will feel that somebody is against them, they will harm them. Sometimes these delusions may even turn bizarre, like feeling that there is something implanted in the body or something which is impossible or implausible. Along with this, other issues like behavioral disturbances, mood features, or problems in memory are also seen. So how do we treat it? Of course, the first line treatment will be antipsychotics. As I mentioned before, atypicals are comparatively better. Uh, there is a high risk of extrapyramidal symptoms, that is, tremors, rigidity, excessive drooling of saliva from the mouth. These are seen common with typicals, and if possible, they should be avoided. Atypicals, yes, they also have their own set of side effects, especially metabolic side effects are very common. So obesity, weight gain, impaired lipid profile. These are very common with atypical antipsychotics given in long term. Now, there is one more illness we need to see, that is delirium. Now, delirium is very common in, say, in your clinical practice also, you all must be seen when a person is feeling confused or having a fluctuating orientation. Now, why that is getting included in my topic is because there are a lot of symptoms in delirium which are actually behavioral symptoms, and very often you see people having illusions much more often than delusions, and hallucinations. And the hallucinations are more commonly visual rather than auditory. So this is a picture which makes it very confusing whether it is delirium or whether it is psychosis. But one core symptom in this will be disorientation will be seen in delirium and not necessarily in psychosis. And this is important to recognize early because we need to treat the medical cause which is causing it, in absence of which the mortality rates are pretty high. So if it is delirium, find the underlying cause, treat the underlying cause. From our side, for especially the disorientation and the behavioral issues, what can be done? What we do mainly is reorientation. Now, see, very often it happens that patients with delirium are, say, admitted in ICU setup, and what we see there is something clinically called as ICU psychosis. Now, that itself is not really psychosis, but a person in an ICU setup who's already having maybe some problems in their metabolic parameters, like, they could be having hyponatremia or some other issues and are having delirium. Now, what happens typically in ICU setups is typically there are light on even the day or the night, or the windows are typically closed. It's a AC setup. So what happens is that the person very easily gets disoriented. So a delirious person has to be reoriented. So reorient, what do we mean? You maintain the diurnal variation. If possible, try to dim the lights in the night so that it becomes a little easier to understand. Or if nothing, at least if the windows could be kept open so that the person can recognize whether it is dark or light outside. You can use any orienting stimuli that, example, in front of the bed, say a clock, something can be kept, or a calendar, which makes them realize what date it is or what time it is. And again, for the behavioral issues, we can give a low dose of atypical antipsychotic. Now we look at HIV-associated neurocognitive disorder. Now, these are also seen in 5 to 20% of cases, where you get a mixture, a spectrum of cognitive, motor, or mood issues. Collectively, it is called as HIV-associated neurocognitive disorder, also in short called as HAND. The dementia also sets in this. The neurocognitive symptoms are very common. So there have been other names associated with it, that is HIV-associated dementia or encephalopathy or AIDS dementia complex. These are seen in 3 categories. That is on there as it gradually worsens. Okay, each is associated with an increasing level of impairment. So the first level is an asymptomatic neurocognitive impairment, where you will see a little difficulty in more in recent immediate memory. A person may be able to have difficulty in where they kept things, may lose things very easily. Or when you test them on MMSE, the scores might be out of 30, might be a little more than 26. So it's very mild. If only the family members complain, or you have noticed or evaluated in any of your follow-ups for on MMSC or any other memory parameter, then you could notice this much earlier on. The second one, the higher one, is in intensity, will be the mild neurocognitive disorder, in which uh, it is much more like this is seen in 20 to 30% as compared to say 30% in ANI, which is the asymptomatic one, which is very often missed, which you all should look for. So the second one is seen in 20 to 30%, where it might be a little more problematic. It might start affecting their activities of daily living, and it might be given in the complaint by the family members that they forget things, or having difficulty in making calculations, or they are making mistakes in their banking or other activities. In case of women, family members might complain that they are not able to dress up like before, or do the task of home like before, or make mistakes in cooking. So these are commonly seen. A more severe one is the HIV-associated dementia. Luckily, this is seen in lesser 2 to 8% only, but this is a much more severe one, which the dementia itself causes a lot of apart from the neurocognitive decline, it causes a lot of problem in the activities of daily living, and they start becoming dependent on others. Now, these again can be mild, moderate, severe. These can be debilitating or terminal. So if we look at it, the activities of daily living, as you see, there is a marked interference in the HIV-associated dementia. And in HIV-associated dementia, it will be at least 2 standard deviations below mean for the normative population. Whereas the other 2, it is only below 1 standard deviation. So what are the predictors? When can you expect a person will experience or is prone for neurocognitive issues? One is any past history of any CNS disease along with HIV, or if there has been a very long course of HIV infection, if there has been any drug and alcohol use, any hepatitis C infection, and very often it is seen when CD4 counts are below 350. Treatment for this again mainly needs to be about ART. So the adherence should be at least 95%, and we require support from family. Psychosocial support is necessary. For diagnosis, neuroimaging, especially MRI, should be good enough. There are certain neurocognitive tests called as neuropsychiatric testing which can be done. Treatment apart from ART, that is the usual way of treatment, could be memantine, selegiline, bupropion, SSRIs, atomoxetine, modafinil, or other medications. Now coming to substance use, these are, as you see, very common. More than half of people could do it. Now, why this is important? Because substance use itself could be a vector for spread of HIV, because under the influence of substance, a person is more likely to indulge in unsafe sexual practices or be a IV drug user, or also you see that there is a role of pro-inflammatory cytokines and changes in neural reward circuitry. Then there could be the synergistic drug use can also worsen the psychiatric symptoms. And sometimes we even have a triple diagnosis. Triple diagnosis is, say, a person who's having already a diagnosis of HIV and goes on to develop, also has a substance use disorder. And along with that, also tends to have a other mental health disorder, like, say, depression. So what is our goal if a person is using drugs? First is try to reduce. If not, if not stop, at least try to reduce the drug use that they are taking and reduce the high risk behaviors. Treatments that we often give is detoxification when the person is abstaining. And in case of opioid use, which is chronic, often they have to check into methadone maintenance programs, which we call it as substitution therapy. Other comorbid conditions, if any, should be treated with medications, as well as psychological treatments like, say, CBT, motivational enhancement therapy, directly observed therapy. Now, let's go to the vulnerable population. That is, say, children and adolescents. Say, in children and adolescents, what do we look out for? What are their warning signs? Like children who are coming for their regular checkups. Of course, one is sadness. Secondly, if they are now withdrawing themselves, they do not play like before, they remain to themselves, or they might hurt themselves or talk also about hurting themselves. It is not very uncommon, trust me. Children do talk about death, or they do talk about dying. Or if a child suddenly starts becoming irritable, if there is a drastic change in their mood, in their behavior, their eating pattern changes, or they don't eat like before, and they do not sleep like before, or they have complaints of pain, that it could be headache, they could have difficulty in concentration, or they have difficulty in studies, or they are missing school, that is something needs to be looked into. So, now we go to the next topic, that is medications, ART itself, okay, which we are talking about ART and mental illnesses. Now, the thing is that when we treat a person for, say, depression or psychosis, so we need to look into what could be the probable drug-drug interactions. Now, if you see that there are no significant drug interactions between NRTIs, NNRTIs, and our medications like amitriptyline or fluoxetine. If needed, then you can increase the levels. Otherwise, by itself, amitriptyline fluoxetine does not affect the drug levels. Now, these should be given in caution. Why? Because amitriptyline is one molecule which prolongs the QT interval. So let's look at ART-induced psychiatric side effects. If we see, many of the medications have some or the other mental health comorbidities as well. So say in efavirenz, you could see depression, dizziness, suicidal ideas or psychosis. Or in NRTIs like zidovudine or abacavir, you might get mania or psychosis. Or say in INSTI, you could get insomnia, depression, suicidality. Now, whenever the person is on ART and has, in the next follow-up, seems to have some psychiatric issues, please do look for if there are any offending agents, the ART could be causing it, and you can consider switching if required to another ART. Now, since that we have covered most of the illnesses comorbid illnesses that we see in PLHIVs, now let's go to a very important topic, that is PHQ-9. This should be done every 6 months. It's very easy to administer, can be administered in your ART clinic itself. There are main two questions. During the past 2 weeks, have you been bothered by feeling down, depressed, or hopeless? Similarly, in the past 2 weeks, have you been bothered by little interest or pleasure in doing things? Now, as you remember, when we had taken the slides before, the depression, the most common mental illness that is seen in people with HIV, one of the two symptoms is required for the diagnosis of depression. So if a person answers yes to any of these two questions, okay, and they have a detectable viral load, they should undergo the screening for depression. So what are the questions which are seen here? Just go through them. One is the core symptom that I was telling you, little interest or pleasure in doing things, feeling down, low, depressed, or hopeless. These are the two core symptoms which you had asked before, and because they have said yes, you are going to apply the full scale. The other 7 questions, trouble falling asleep or staying asleep, feeling tired or having little energy, having poor appetite or overeating, feeling bad about yourself, feeling guilty, feeling that you're a failure, feeling that you're let yourself or you're let your family down, trouble concentrating on things. The next symptom is for psychomotor retardation. So you ask a person if they have a difficulty in moving or speaking slowly. So if people have also noticed it, or the opposite, if they have become very agitated, so they have become fidgety or restless than usual. And the ninth is whether they get thoughts that they were better off dead or that they should hurt themselves. Now, these should be scored on a 4-point scale, from 0 being not at all to 3 being nearly every day. So 1 is for several days and 2 is for more than half the days. So all these 9 questions on the same 4-point Likert rating, 0 not at all, to the highest being nearly every day. So if you add up the score, what you get the total score. Now there is an interpretation to this. So say a score 4 or lesser, depression is unlikely. And you repeat the screening when the person comes next as per schedule. So that should be 6 months. Say a person scores 5 to 9. The depression is mild. In which case, what do? We provide supportive counseling. We continue to monitor. In this case, specifically efavirenz, if the patient is on EFV, you substitute with a different ART. Okay, after ruling out treatment failure. A little higher score, that is 10 to 14, is more moderate. And 15 to 19 is moderate to severe. And 20 to 27 is severe depression. In this case, the recommendations are similar. One is that supportive counseling through trained counselor. I believe all the ART centers have a counselor. So the supportive counseling should continue, whether it was mild, moderate, severe. Second, similarly, if EFV was going on, try to substitute. Third, here what it is different is for any moderate or like score 10 and above, you refer to a psychiatrist for further assessment and whether any antidepressant is required. PHQ, why I'm saying is very important, that it's easy to do in the setup itself and it is given in the recommendations. Day to day, when you're using it regularly, you'll realize it is much more easier to administer. It is also available in local languages. So it becomes very easier to apply in all setups. So now we look at the second case study. A 35-year-old woman was diagnosed with HIV 2 years back. She's on ART TLD regimen. She had financial problems. Her viral load is suppressed, which was done 4 months back. She presented to the center and the counselor could observe that she was feeling low and she applied the PHQ-9. On which she responded, she feels low and depressed on almost all days, poor appetite, feeling tired on more than half the days, trouble in sleeping on several days, loss of concentration on all days, restlessness on several days, and thoughts of dying on all days. Now, what we had covered just before, can you all calculate the PHQ-9 score and what's the most likely condition? Go through each and every symptom. One, if you look feeling down or depressed, almost all days. If you remember, the rating that we had was 4 point Likert, 0 not at all, 2, 3 was nearly every day. So this becomes every day. The second one is more than half the days. So that is a score of 2. Trouble on sleeping on several days. So that becomes score 1. Loss of concentration on all days. So that will become score 3. Restlessness on several days. So this you can take it as more than half the days. So it can be taken as 2. And thoughts of dying on all days. So this is a higher one. So you take it as 3. So as you see, the score is coming out to 15. So 15 comes it, score, the cutoff was 10. So 10 and above was moderate to severe depression. So in moderate to severe depression, how do we manage? 3 things. First, which is common, that is provide supportive counseling messages, supportive counseling through the trained counselor. Check which molecule the person is on. If possible, substitute it if there is once you have ruled out treatment failure. And in this case, since this is moderate to severe, you should refer to a psychiatrist for further assessment and antidepressant medication. So now we look at what are the key supportive messages. One is psychosocial support. You should explain what is depression, assure it can be managed. The symptoms that they are feeling is a part of depression and will improve with proper counseling and treatment. You inform what the course will be. Very important is to identify who is the supporting person in the family and involve them. If possible, involve peers, involve the community support groups also. You should continue the ART, identify the activities that a person can find interesting and try to involve them in that. Involve them in physical activities. You can contact the ARTC or healthcare facility immediately if there is any thoughts of self-harm. Try to identify what are the stress points. Okay. Discuss and try to solve them through problem-solving techniques. And stress management techniques can be recommended, like say meditation and relaxation treatment. So tips, general tips, always take your treatment regularly. Regularly converse about mental health. Discuss what drugs they are using. And generally, you should always inquire and advise them to have adequate sleep, healthy diet, have a confidant, and restrict the screen time. Anything which works also for the physical health also does work for the mental health. Now we look at the NMHP. Now, NMHP was launched by Government of India in 1982 with the objective to ensure one, availability and accessibility of minimum mental health care for all. Second, to encourage application of mental health knowledge in general healthcare and in social development. And 3, to promote the community participation. So what are the strategies? See, in general primary healthcare, mental health should be integrated. 2, for mental disorders, tertiary care institutions, the options should be available for treatment. And last but not the least, a very important point is to eradicate the stigma which comes along with this. Because it is now both ways. Say they are already living with HIV and they also are suffering from mental illness, both which are considered to be stigmatizing, and a lot of work needs to be done in that. There are certain bodies, that is the CMHA and the SMHA, who are the regulatory institutions for mental health. Now let's look at the DMHP, the District Mental Health Program. This is since 2003. So here, what are the components? So you manage cases of mental disorders and counseling should be given at the district health level. Manpower training and development should be done for prevention, then early identification and management of mental disorders. And awareness activities are very much required. The objectives of these are to provide a sustainable basic mental health services in the community. and to integrate this with other all available services so that you can detect an illness, mental illness early and treat it in the community itself. So it takes the pressures off the mental hospital or the tertiary care centers. And we need to reduce the stigma. So that's where the awareness comes in. You can rehabilitate people in their own community setups. And also one of the point in this is also epilepsy management and treatment and reference. So the services include outreach services, all ground level workers who work very hard, that is the ASHA workers, the ANMs, the Anganwadi workers, who can identify and refer these cases. We should train the medical officers to identify and start the first line treatment, which can be done very easily even at the PHC level. Then IC activities can also be done at the PHC level and targeted interventions, workplace stress management, suicidal prevention treatments. These all should be given. So where does this role of ART center stand? First and foremost, very important, very easy to do, screening by PHQ9, which one of the case we just did before this. It doesn't take much time and it should be done regularly as per schedule. Then when required, referrals can be done with mental health issues to the neighboring Department of Psychiatry. Should identify the early warning signs. Some of this we have discussed in the slides before. Counseling of mental health issues, those who are having psychiatric treatment, monitoring them, providing them psychosocial support, helping them with self-management skills. And it's very important for adherence counseling for both ART as well as psychiatric medications. Identify the family members who can be supportive, involve them, involve peers, if possible, also community support groups, and integrate these mental health services into our routine healthcare services and the coordination with the concerned hospitals. So to conclude, there are many varied mental health disorders. The relationship of mental health disorders and HIV is bidirectional. It's neglected very often. So it's very important for us to identify, to look out for them. Why? Because their presence will compromise the HIV care and prevention efforts. And if left on themselves and they are left untreated, they will compromise and worsen the treatment outcomes. They may cause pockets of potential HIV spread and in general will have a poor quality of life and there will be greater disability. So screening for mental health amongst PLHIV is very important and it is necessary to integrate them in routine care and prevention programs. So thank you. Any questions?
Thank you so much, ma'am. Any questions? Kiran sir, can you please give mic access to everyone? Questions in the chat box. We are giving mic access.
Okay.
Participants can now unmute and ask questions. Any questions or anybody would like to share their experiences around mental health?
I'm sure many of you all must have experienced or seen cases. Yes, like we have one comment that mostly patients don't want to involve family members or even friends. Yes, that is a very common problem. Even we see in our practice. Very often people have a lot of stigma. They do not want to disclose or they do not want to share their vulnerability with their close people. So it is difficult. As far as possible, what we also do is we try and encourage them to involve the family members. Though sometimes, especially if there are suicidal thoughts and ideations, yes, we might have to push them. But otherwise, with a regular rapport, at least in our practice, we have seen that after some months of follow-up, people do tend to involve their family. Though yes, what is written is true that many young persons come alone and no one else knows. So that's true. That's when they will not want to. But I think it's very important to make them realize that they need not disclose to everyone, but everyone would need a confidant. That's what will help them and protect them also.
Thank you, ma'am. Any more questions or anybody would like to share their experiences? You can unmute now. Ma'am, I don't think there are any questions. Thank you so much for your time and for facilitating this session.
Thank you. It was a pleasure to be here, and I thank you all for giving me the opportunity.
Thank you,
And
ma'am.
yes, it was a nice session. Thank you.
Thank you, ma'am. Kiran sir, can we quickly run the feedback poll? Thank you. The feedback poll is now visible on your screen, requesting participants to please scroll through all the 5 questions and answer them. You will have to click on the answer of your choice. Please read the last question carefully. Requesting participants to please complete the feedback poll before leaving the meeting. We'll wait for another 2 minutes. Kiran sir, we can end the e-poll now. Thank you to all the participants for patient listening. We'll conclude the session now. Thank you, ma'am.
Thank you. Bye.